How about some of the other mutations beyond the top three? What happens if somebody is tested for the top three and it's not there? What's the practical next step for that patient?
I'll just say two quick things about that. First of all, I sometimes get those referred to me, and they've done the blood test 4 times and come back with the same, it's not one of the 3. The blood tests are really accurate. Doing it over and over again in this particular case, I don't think has much benefit. 2 is that in the old days, we didn't always have these blood tests, and I don't think there was any ambiguity. We knew what Leber's was, and we still do. So it happens 5 or 10% of the time that I get the patients returned back without the 3 mutations being known, and I'm still sure it's Leber's, and it's one of the 5% that haven't been characterized. Although of those 5%, the number gets reduced all the time because, and that's what I do, is I save the bloods, send it to him, and when he gets around to it, which might be a while, he will characterize the entire genome and find it for us.
Yeah. Nowadays is an easy procedure and relatively inexpensive to sequence the entire mitochondrial DNA. So we published a few years ago a bunch of rare so-called mutations, which are truly mutations, are not polymorphic variants. There are some criteria in order to prove that the variant is a pathogenic mutation, and now we know how to do it. So if the clinical picture is unequivocal, as Alfredo says, this is Leber's. I don't care if there is no classical mutation. It is Leber's. And in particular, if there is maternal inheritance, you are you're sure 100% that you're going to find some variant which is causative of the disease. The only thing is that the severity of this mutation may change depending on where the mutation is located. So we are now aware there are a bunch of mutations which can be heteroplasmic, and within certain amount of heteroplasmy they can produce Leber's. If the heteroplasmy is higher, and they can actually give other symptoms, and these are mixed phenotypes or overlapping phenotypes. And if you want, we can discuss a little bit that. But in many cases, you should do the sequence if you want to be very sure on something that is not blood, but it would be more useful the urinary sedimentum, the epithelium from the urinary sedimentum, or in the best, I mean, the gold standard would be in the muscle biopsy.
Did you have more to add?
No, essentially, I was going to say that's where progress has been made, because 10 years ago, people would say that the 3 primary mutations would account for 95% of cases, but now because people have more access to whole genome sequencing, it's probably 90%, because increasingly you find these rare mutations, yes, but when they come to major centers, it's not that rare, because it's a self-selected group of people you're doing whole genome sequencing on.